Now, let's move to session two, uniting. We know what works. Let's do it. Many of us have had the pleasure of working in Janet Wright's aura during her tenure as Senior Vice President of the American College of Cardiology, or as Executive Director of Million Hearts, or Chief Science Advisor to the Surgeon General, or as Director of CDC's Division of Heart Disease and Stroke Prevention. Today, we are honored to have Dr. Wright, a rabid advocate for cardiovascular health and a National Forum Advisory Leadership Council member, leading us through this next conversation. Dr. Wright will set the stage and introduce our speakers. Janet, thank you for your leadership and commitment. The floor is yours.
Good afternoon, everyone, and thank you, John, for the kind introduction. I am delighted today to facilitate session two, Uniting. We know what works, so let's do it. This session will spotlight high-impact opportunities and real-world examples that help people make prevention part of everyday life. We'll focus on three themes. First, reducing the lifetime accumulated risk by elevating prevention in childhood, adolescence, and early adulthood, starting off strong and healthy. Number two, preventing linked conditions across cancer, diabetes, heart disease, hypertension, kidney disease, lipids, obesity, stroke, and brain health. And finally, closing the urban-rural gap in cardiovascular and metabolic health. I think diminishing the importance of the zip code so we raise the boats for all and eliminate that disparity gap. Just a reminder, you can submit questions anytime using the Q&A feature. Please send them as they come to mind. We'll collect and curate them for the live Q&A. We're fortunate today to have three outstanding speakers, three outstanding leaders with us. First, Stephen Daniels, MD, PhD. He's the professor and chair of the Department of Pediatrics at the University of Colorado School of Medicine and pediatrician in chief at Children's Hospital, Colorado. He's going to address early life interventions for prevention and how we can lower lifetime risk starting now. Next, Anand Parekh, MD, MPH, Chief Health Policy Officer and Adjunct Professor in the Department of Health Management and Policy, and Senior Advisor at the Institute for Healthcare Policy and Innovation, the University of Michigan. He's going to speak to preventing the multiple linked conditions through shared and scalable strategies. And finally, Karen Joint-Maddox, MD, MPH. She is co-director of the Center for Advancing Health Services, Policy, and Economics Research at WashU in St. Louis. She's going to focus on reversing the rise in urban and rural disparities with practical models that fit local realities. So first, to kick us off, Dr. Daniels, thank you for being here, and the floor is yours.
Thank you, Janet. The risk for cardiovascular disease is a lifelong risk, as depicted in this slide. We know that atherosclerotic cardiovascular disease is the number one cause of death in the United States and in many other countries around the world. Historically, it was thought of as an adult problem, but as you can see here, it is a disease process that begins in childhood and progresses throughout life and is largely asymptomatic until the challenges of myocardial infarction and cerebrovascular accident occur later in life. As you'll see on the next slide, we finally have evidence that from the I3C consortium, this is a group of international studies that have shown that risk factors measured in childhood are directly associated with major adverse cardiovascular events in adulthood through cohorts that are followed over the life course. And traditionally, this is how we've thought about this for smoking, obesity, blood pressure, dyslipidemia, as identifying individuals at higher risk. However, in the next slide, as you'll see, Dr. Stamler and others flip this issue around to show that actually we should probably be focusing also on low-risk individuals, those with cardiovascular health, as opposed to cardiovascular illness. And as you can see in the Mr. Fit and Chicago Heart Association cohorts, they identified low risk by low serum cholesterol, low blood pressure, not a smoker, no diabetes, and no ECG abnormalities. On the next slide, we'll see results that I think are amazing, and they show that actually those who are able to maintain cardiovascular health or low cardiovascular risk have a dramatic decrease in cardiovascular disease mortality, all-cause mortality, and even a substantial greater life expectancy. What's interesting here on this slide is that if you look at the Chicago Heart Association men in the younger age group, the greater life expectancy approaches 10 years, suggesting that starting early in life actually can have an even greater effect than starting later in life with cardiovascular health. Next slide. Nori Allen at Northwestern has shown that actually the genetics of ideal cardiovascular health are a relatively small component of this picture. Only 17% can be attributed to genetics, which means that roughly 85% of this is attributable to lifestyle, things such as diet and physical activity. Next slide. So this has led the American Heart Association to present the concept of life's essential aid, as you can see here. And these are the factors that maintain ideal cardiovascular health and reduce risk. And you can see that these are the kinds of things that we should be focusing on from a life course, lifelong perspective. Next slide. So here's how we're doing. This is looking at the health behaviors in children. And if you start with the upper left-hand corner, you can see that with respect to diet, we are not doing very well. You see the bars more to the red than to the green. We do better with nicotine exposure, although this is potentially a later in life exposure. We do somewhat better in sleep health, and again, not quite as well in physical activity. And you can see it broken down here by gender and by age group, and also by race and ethnicity, showing some differences across different populations. Next slide. So what this shows is that we are actually losing a precious resource as individuals go from age 12 to 19 up to age 60 and greater. So you can see in the yellow, greater than or equal to 5 metrics, declining with age. And you can see in the green, greater than or equal to 6 of these ideal health metrics, actually starting low, but continuing to decrease. So clearly work for us to do as we think about child and adolescent health and how it progresses through the lifespan. Next slide. So what can we do about this? I think the key here is that we should be addressing with every child and adolescent and their family issues that speak to, in this case, physical activity. And you can see we should be asking them, how do they spend their day? How much of it is spent in physical activity, and how much of it is spent in sedentary time, so that we may be able to change the dynamic and increase their experience with physical activity. And on the next slide, you can see the questions related to nutrition. We need to understand the patterns of eating and how we can move children and adolescents to a healthier pattern of eating, so that we can have more of our children and adolescents in that healthier category related to diet. I think we can do this, and I think if we continue on that path, we can dramatically improve cardiovascular health. Our job, I think, as pediatricians is to deliver children and adolescents into adulthood in ideal cardiovascular health so that they can maintain that throughout the lifespan.
Thank you, Dr. Daniels. what I really appreciate is not only did you lay out the case, but you gave us specific actions that we can all entertain. I don't know if you meant those questions just for pediatricians to ask, but we can ask those in school surveys and in all kinds of offices and in encounters with kids. I've written them down now for my grandchildren. So you've grounded us in what works early and why it matters. As we look beyond these single conditions, our next focus is on prevention that travels across multiple diagnoses. I'm pleased to welcome Dr. Parekh. He's going to share how aligned strategies can reduce the risk for many different conditions, this sort of syndemic idea. Dr. Parekh, thank you for joining us.
Thank you, Dr. Wright, for that introduction. Thanks to the National Forum and John, and great to be on this panel with Dr. Maddox and Dr. Daniels. So the title of my short talk is this very lengthy title. In fact, it's probably the longest title I've had to date. It's provided by the National Forum, but in many ways, the length of the title makes the point. Because if we really want to reverse the cardiovascular epidemic in this country, by doing so, we would also reduce the morbidity and mortality from so many related conditions. And that's because all of these conditions have many, many common risk factors. Next slide, please. So a bit of an orientation in terms of my perspective. I started my public service career first as a clinician and then as a policy expert focused on individuals who have multiple chronic conditions, not just one, but 2, 3, 4, 5, 6, 7 concurrent conditions. And we see so many more Americans with multiple chronic conditions, given the aging of the population, the continued existence of chronic disease risk factors, really the marvels of modern medicine. And so really our initiative at Health and Human Services was to optimize the quality, the health and the quality of life for individuals with multiple chronic. We focused on a number of different goals. And one of the specific projects that we undertook was partnering with clinical practice guideline developers to ensure that clinical practice guidelines on index conditions add information about important and prevalent comorbidities. Next step. And one of the efforts that we undertook was a partnership with ACC as well as AHA, next slide, please, where we looked at some of those most common conditions with common cardiovascular conditions like ischemic heart disease, heart failure, atrial fibrillation. You see here on table 1 some of those most common comorbidities. And then in table 2, you see some of the most common dyads and triads. And so the question of why do these conditions cluster together is, in fact, what I just spoke about, that the underlying risk factors driving many of these conditions are virtually, next slide, please. And so later in my career at HHS, during public service, I focused less on chronic disease management and more on chronic disease prevention. And this is one of the examples of efforts that we undertook working with the Centers for Disease Control and Prevention, focused on getting at those common risk factors outside the core adolescent setting. And as Dr. Daniels mentioned, many of these risk factors, like physical activity, tobacco use, sodium, added sugar, and nutrition, are really driving the cardiovascular disease epidemic in this country. And what we found was that if we could take a number of evidence-based strategies, like focusing on immediate counter appetite, or accessibility, or point of purchase, price and affordability, support services, what we could do is really change the underlying systems and environments so that for individuals, the healthy choice becomes, in fact, the easy choice. Excellent, please. That really sort of led to this idea for me after spending time at Health and Human Services, that where we really needed to go in this country was to form a prevention first agenda. And this is very much in line with what the National Forum has talked about, really achieving a prevention first vision, setting prevention as a top priority for policymakers. There are a number of ways we can talk about how to do that. For example, develop quality metrics, and quality metrics or currency that drive value-based healthcare transformation. But we need quality metrics that focus on the incidence of chronic disease and the prevalence of chronic disease risk factors. We need to measure and set targets for primary care spending. As we know, primary care is so critical as the place where a lot of cardiovascular risk takes place. We need to increase per capita public health funding and the important complementary role that has to clinical prevention. So there are a number of things that we can do to achieve a prevention first vision that will also simultaneously reduce morbidity and mortality cardiovascular. So please. And so a couple of opportunities, I think, near-term opportunities for industry, for health plans, for payers, for health plans and payers, for providers, for health systems, as well as community-based organizations are to engage in public-private partnerships that get at some of these underlying risk factors. Now, we saw for 2 or 3 decades a significant reduction in deaths from cardiovascular disease in this country due to tobacco control and prevention efforts, and then broader cardiovascular prevention management efforts. But over the last 10 or 15 years, we've seen a plateauing in that decline because of increased or worsening control in all those factors that Dr. Dan has talked about: glycemia, blood pressure, lipid control, alcohol consumption, obesity, persistent socioeconomic disparities. And so the question is, how do we resume decline? And here are just a couple of examples where federal leadership is critical, but really public-private partnerships that get it. For example, sodium reduction. So in this country, we know that we consume too much sodium. We were at about 3,400 milligrams per day. We're at about 3,100 milligrams. We currently have voluntary sodium targets through the FDA to get to 3,000. They've just recently published draft targets to get to 2,750, but really working with the industry to reformulate products to reduce tobacco or sodium content in a variety of different products. Absolutely critical. Probably ought to do the same with added sugar. There's dietary guidelines for Americans, but no more than 10% of calories should be from added sugar. We're at about 13-14% population-wide, so 30 to 40% higher than the upper limit. So the same idea, sort of working with industry to reduce added sugars in a variety of different categories. And then on the healthcare side, there are a number of opportunities there, and a couple listed here. So it's the diabetes prevention program, which many of you are well familiar with. Evidence-based, intensive behavioral modification intervention focused on diet and exercise, which reduces the progression of prediabetes and diabetes. To give you one example, in Medicare, we have 25 million beneficiaries of prediabetes, yet only a couple thousand are currently actually benefiting from the diabetes prevention program. So how do you scale that? Obesity management. There are a number of evidence-based interventions, from intensive behavioral counseling and nutrition therapy, now pharmacologic agents. How do we increase access to these evidence-based therapies? And then certainly, as Dr. Wright has led for over a decade now, the important work with the American Hearts Initiative and the important opportunity, particularly for blood pressure control, through both provider incentives as well as educating their patients. So I think there are a number of near-term opportunities that get at those common risk factors again, that will not only help us tackle the cardiovascular disease epidemic, but all of those linked missions that were in the title of my talk. If we can get at those risk factors, then we can really address morbidity and mortality from all of them. And then, of course, what's not listed here is continued focus on tobacco control and prevention that hasn't contributed to the plateauing, but there's still much more work to be done. So looking forward to discussing this more in greater detail. But thanks so much.
Thank you so much, Anand. I love the way you bring public health, healthcare, particularly primary care, and policy all in a bundle and focusing out on prevention. It's a beautiful thing to see, and I've seen you in action. So now, in talking about prevention, we know that health begins at home, prevention really begins at home, and in homes in rural and urban environments, we're seeing quite a difference in terms of the disease burden. So Dr. Karen Joint-Maddox, you are here to highlight ways that we can help those communities both raise the bar, but eliminate the gap. Karen.
Thank you, and it's an honor to be part of this group, and I think you'll hear some common themes in what I will comment on today. I'll also say, as an adult cardiologist, I would like to be put out of business by the pediatric folks and prevention folks in the room, but thus far we've stayed plenty busy. So next slide, please. So the first thing I'd like to point out is that actually rural health inequities are a pretty recent phenomenon and have been widening quite quickly, suggesting that there really is some difference emerging between urban and rural areas that is driven perhaps by access to care and other things that we'll talk about. But really through the mid-1980s, rural and urban death rates were fairly similar. And since that time, we've seen death rates in urban communities continue to decline, particularly in wealthy urban communities, while we've seen a real plateau, as was mentioned earlier, in overall progress in rural areas. On the next slide, you can see that cardiovascular disease and stroke are major drivers of these decrements in rural mortality. You can see where the red areas are sort of the hot spots of cardiovascular mortality, but I'll say again, in reflecting on the prior speakers, you could put cancer mortality, you could put many, many other things in that same map, brain health, dementia, because all of these things are really driven by a set of common underlying factors that are clustering in areas where we see rurality, poverty, community disinvestment, and a number of risk factors come together in particularly vulnerable communities. On the next slide, you'll see a few thoughts about why. So the traditional and emerging risk factors, social determinants of health, healthcare infrastructure, insurance access, quality, and capacity. So on the next slide, we know that in rural areas, traditional risk factors that used to be lower in rural areas are now higher in rural areas. You can see here data on hypertension and diabetes, as well as obesity and mental health, all both worse in rural areas and worsening in rural areas compared to urban ones. I'd particularly draw your attention to obesity and the suicide rates in the bottom right, which I think are areas where perhaps there's not been as much conversation around the change in urban versus rural areas and the degree to which mental health in particular really may drive a lot of commonality among disease increases. Next slide, please. We also know that there's many social determinants of health that are linked to health outcomes that are also increasingly common in rural areas. So poverty, historically, we think of poverty as maybe being sort of the urban poor, but in reality, poverty rates are significantly higher in rural areas, and the resources that people have to avail themselves of food pantries and other support are lower in rural areas. And so you see greater food insecurity in rural areas and actually a growing housing crisis in rural areas as the housing stock ages and community disinvestment grows. On the next slide, we also know that infrastructure is worse in rural areas and again, headed in the wrong direction. So on the left, you can see levels of uninsurance, and you can see, testing my geography here, Texas, Georgia, Florida, Mississippi are hotspots of uninsurance, and some of those places overlap in the same places as we see adverse cardiovascular and metabolic outcomes. And then on the right, health professional shortage areas. And again, you'll see the same overlap of areas where we have rurality, poverty, community disinvestment, where we see access issues in, for example, both hospital facilities and primary care. On the next slide, we'll try to talk about a few possible solutions, though I will say that as a policy person, these sort of can't high. And we also obviously need to think about designing solutions for local areas. But I think unless we think about the policy solutions, we're unlikely to support sustainability in local investment. So we always hear about telehealth for rural areas, and I think that's certainly worth supporting. I will say, however, that the greatest users of telehealth post-COVID are urbanites who are trying to get around a lot of trouble with the inconvenience of healthcare. So telehealth is actually used at about double the rate in Medicare in urban versus rural areas. It is helping close the gap, but it is not in and of itself going to solve the problem. Necessary, but not sufficient. Insurance expansion, you can see there the latest map of Medicaid expansion demonstrating a clear geographic patterns in where Medicaid has not been expanded and where we see the highest rates of uninsurance. We know that children are more likely to be insured up until they reach adulthood, but there's a real cliff around the ages of 18 and 26, where we see children start to enter a phase where they have the highest uninsurance rates right at a key time in life for developing positive cardiovascular habits. And then I think I'd be remiss to not mention the importance of investment in rural areas. On the graph on the right, you can see the recovery of employment in urban versus rural areas post-COVID, demonstrating that urban has essentially recovered and rural is lagging quite a bit behind. Next slide, please. So overall, rural health disparities are large and growing, and cardiometabolic disease is a key driver, both of cardiovascular disease, but again, also of cancer and brain health and dementia and stroke. The causes are multifactorial, and we have to think about both the standard and emerging risk factors as well as social risk, which I think is the most quickly widening gap with rural America. Healthcare access and quality are challenges, and solutions include telehealth, insurance expansion, and broader infrastructural investment. I will also echo the prior speakers in saying that without a national focus on this type of work, local efforts can only go so far. And so I think it's incumbent upon all of us to be able to think about how to design community-informed local programs, but also recognize none of those are sustainable without policy action to make sure that resources can be delivered where they're needed. Thank you.
Thank you, Dr. Joint Maddox, for those concrete approaches to fairness and to access. Each of our panelists has given us a strong foundation for discussion. Dr. Daniels, I'd love to come back to you with a question about how to operationalize those questions that you shared with us. How can we put those into practice, whether we are in public health, in healthcare, in a community-based organization? They're such important questions.
Yeah, thank you. I do think they're the kind of questions that don't need to be just focused in a pediatrician's or a family physician's office. These are the kinds of things that should come across in schools. They should come across in a number of settings where children and adolescents spend their lives and where decisions are made around lifestyle factors, which we know are so important. So it would be great if those kinds of questions and the responses to answers could be happening at multiple venues, multiple levels, throughout multiple ages, because I think these need emphasis and re-emphasis as we work towards healthier kind of lifestyles for children and adolescents.
Thank you. Thank you for that. Those are good marching orders for all of us, wherever we sit or stand. Dr. Parekh, I know your passion for policy and your ability to analyze things that are effective and hone them so they're more effective. When you think about the programs that you led during your department days and even at the Bipartisan Policy Center, are there lessons you could share with us about how to expand or get these things that are well designed, but how to get them more rapidly implemented? What's in the way of the implementation piece? It's always the hard thing.
Yeah, no, I think it's a great question, and my experience is that I think in many ways we know what we need to do. We just need to elevate these issues really to the top of the mind of policymakers and leadership, and align them in a way where it corresponds to their vision. So when we talk about whether it's MAHA or the children's chronic disease epidemic, we ought to be talking about all of these underlying risk factors that we've been talking about today, whether it's better nutrition or reduced screen time or increased physical activity. And so ensuring that policymakers understand that what we're talking about here not only has a disproportionate impact on the health of the nation, but is very much in line with, frankly, reversing the children's chronic disease epidemic in this country. And so sometimes I think it's making that connection, ensuring that policymakers and healthcare leaders know, and then providing them that menu of evidence-based programs, activities, and initiatives. I don't think we really need to reinvent the wheel. Certainly, we always need new science and new research, but we know what works when it comes to cardiovascular risk factor reduction in so many of these critical areas. It's more a question of implement that and prioritize that. Having the funding for the programs also critical as well. And we talk about some of the concerns and risks in the federal environment, but it's going to be really important to maintain these evidence-based these programs because they're the ones that can lead implementation of evidence-based interventions with the private sector, of course.
You said so much there, and I'm going to ask our other two speakers to weigh in on their thoughts on implementation. I think we'd all agree that's hard, and maybe one aspect that makes it so hard is its sustainability. The sustaining a focus on a particular intervention or set of strategies over time, and that gets at funding. It also gets at what a leader's priorities are. So let me open the floor for Drs. Maddox and Daniels to comment on how can we accelerate the implementation of what works.
I'm glad to jump in on a few policy thoughts. You'll be shocked. I think that we have made such a complex stew of value-based and other sorts of payment programs, and in doing so have really missed an opportunity to use value-based payment to focus on prevention. I think we've seen from the advances, for example, in survival for acute myocardial infarction or stroke, right, which continue to improve, those are doing great. There are financial incentives, there are technologies, there's a lot of momentum behind treating the big, scary acute disease, and we should keep doing that. But where there's sort of a collective action problem and where I think policy really needs to focus is on prevention. That's not anyone's sort of exciting, pricey thing right now that's going to get hospital executives excited. That's what policy's for. The policymakers have to sort of protect the common interest in a way that goes beyond the shiny objects. And that, I think, means really streamlining our approach to payment to focus on rewarding prevention. As Dr. Parekh mentioned, we don't have many things that reward people for reducing the prevalence of chronic disease, right? We really want to make sure everyone gets their aspirin if they have a heart attack. We should keep doing that. But what about not having heart attacks in the first place? We need fewer heart attacks in the first place, and that's not captured anywhere in a way that's really sort of central and meaningful to most health systems right now, particularly in sort of the consolidated environment in which we find ourselves. So that's where I think we need to push.
Karen, I have to jump in, and Steve, I'll turn to you, but I just want to say viewing heart attacks as a failure, like a failed. If somebody had a heart attack, that's a failure. It may not be my failure, but it is a failure of the whole system of prevention and public health and healthcare. Steve.
Well, and I think we could say that it probably is a failure that we haven't put Karen and her colleagues out of business because we really do have the means to do that. I'd like to go back to one of Anand's earlier points, and that is figuring out ways to make the healthiest choice the easiest choice. Because in many cases, it's the exact opposite of that. It's, we have children who every day face this gauntlet of decisions about their lifestyle that are made more difficult than they should be. And we need policy that helps direct those decisions in the healthiest ways. I think the initiative to lower sodium in foods could be incredibly effective. My sense is that nobody would even notice if we did it gradually, and it could have a dramatic impact on health. I think the same could be true for added sugars in a variety of foods and drinks. So those would be the kinds of things that not only would be good in the short term, but I think actually could be quite sustainable.
Let me go back to something that I think each of you touched on, and that is this. I'll say from my own observations, I've heard much more lately about local and state work than federal work, and yet you've each indicated how important it is to have both. Could we go a level deeper on that and talk about what is necessary from a federal standpoint, and how can we fuel further work at a local level?
But well, I can start because I do think that there'll be some mitigation work that's going to happen at the state local level over the next few years, even likely cuts or presumed cuts to Medicaid, as well as cuts to SNAP. And so when you think about how do we optimize cardiovascular health, if you have more Americans who are food insecure, you have more Americans who are uninsured, as Dr. Maddox mentioned, both through Medicaid or the individual markets. So foreshadow a year, 12 months, 18 months from now, we could be looking at a situation where we have millions more who are uninsured and food insecure. And that's just going to make our job of cardiovascular risk reduction and prevention that much more difficult. And so I think states and localities are really where this is going to play out, and mitigating those impacts in a variety of different ways. State Medicaid programs will be critical. How you use the state rural healthcare transformation fund is going to be absolutely critical as well. How at the local level, even though they're strained, how community-based organizations can be supportive to whether ensure that individuals have a legal source of care or they have access to healthy food. So I do think that at the state local level in the near term, there's going to be a fair bit of mitigation given some of the federal policies that are coming down its way. Beyond that, I do think that it's really scaling a lot of what we know, but I'd love to hear what the fellow thinks.
Yeah, I mean, I agree with all that. I think to see the importance of local and state action, you only need to look at the map that shows you how different outcomes are already and how many decisions have previously been made to either support health or not support health. And I do think that we have seen, regardless of red or blue, we have seen different states take different approaches to how they think about public health and prevention. And so there ought to be a lot of ways we can learn from this and try to understand. And we do a lot of work with the state of Missouri. And it doesn't do any good for me to go to the state of Missouri and say Massachusetts had a program that did X, Y, and Z. But it sure does to go to them and say, hey, Mississippi came up with this thing. Look at their education program recently, right? I mean, there really are examples where states have been very creative with very specific things. And so states need to learn from each other. The rural health bill is a great thing to bring up. That's a lot of money. And states are really thinking actively about how to use that in prevention. And so we'll have an opportunity for states to learn from each other about what they can do to mitigate, to promote, right, in places where they're doing a pretty good job. So I think it's more important than ever that states are engaged on prevention because they have an opportunity to do something right now.
Yeah, I agree. It does take both. I think what's missing is the conversation about the incredible return on investment by improving cardiovascular health or health in general, because as it turns out, and as Anand showed, it's not just about cardiovascular health, it's actually about overall health, and including mental health, which is a clear focus these days. The kinds of lifestyle factors that we're talking about have such people have said, if we were talking about a medication here, everybody would be lined up to take it. And yet we're not really making the case well enough, perhaps, that the benefits and the lifelong benefits are there with these kinds of lifestyle approaches. So to me, we need to figure out how to get people talking that way, as opposed to talking about all the barriers and how hard it is and et cetera, because it seems like these are problems that can be solved.
Steve, it's kind of scary. I had just written on my little yellow pad here as a final question for you all. We'll make a lightning round. I'm going to warn you about what that question will be. I'll tell you what it's going to be. It is the business case for prevention. To make your pitch as the business case for prevention, imagine you're talking to decision makers. So I'll give you time to think about that, because I'm going to go back to Karen with a question about rural health and specifically rural telehealth. because when I first saw that statistic, it surprised me a bit. And I'm wondering how broadband access is wrapped up in that finding, or what are the other factors that do we know why urbanites have adopted telehealth much more rapidly than rural folks?
We don't know exactly, although I'll say it's been seen in a number of studies that post-COVID adoption in rural areas is lower. Part of it is internet access, although for most of the US, there is decent internet access. So I don't think that's the whole story. It certainly is in pockets, but I don't think it's the whole story, because you see small towns down there also, and they typically do have, better infrastructure than true sort of remote areas. I think part of it is cultural. And I actually think part of it is that people are using telehealth to connect with their local providers. So if there's an absence of local providers and an absence of local infrastructure, you don't have the people on the other end of the telehealth, if that makes sense.
Yep.
It's like how you can, if you know somebody already, you can have a Zoom call with them and feel very comfortable. But if you don't, it's kind of weird. Body language and sort of how do you work in a group? And I think that for people who may lack the opportunity to connect with a range of clinicians, telehealth doesn't fix that problem. It's a good way to stay in touch. I don't think it's a good way to establish relationships. And so I think we need to think about a combination of strategies to make that more effective than just sort of, here's the internet.
I was surprised with how much coaching an individual needs to do self-measured blood pressure monitoring. You can give them a handout on how to use the device, but transmitting those readings to a clinician, people need someone to coach them. And Steve, I saw your head nod. You agree, or do you or Anand have other comments about the rural-urban divide and telehealth use there?
Well, one of the things about telehealth that I think might be underutilized, and I get information from our dietitians who do telehealth, and they actually really like doing telehealth with the patient and their family in their home setting, because it allows them to get a better sense of what that home setting is really like, and perhaps make more informed discussion about how changes could be made. And I think that probably applies across urban and rural settings, and may actually improve our understanding of the different settings that patients find themselves in. So to me, it seems like, we learned a lot about telehealth related to COVID, but there's still a lot of things both on the positive side and potentially on the negative side that we need to work on.
Great.
Yeah,
Steve, how's that
add,
visit paid for? Sorry, none. How's that visit paid for?
Well, under the emergency order for COVID, it was paid for, and it worked out really quite well. So to me, it seems like, the answer is obvious. It needs to be paid for, and it needs to be, in our case, it's probably true of Karen too. We work across state lines, and so it really has to be available to have that kind of dynamic to make it work effectively.
Yeah. Anand, sorry I interrupted you.
No, I was just going to add that on the telehealth side, this is another one in the mitigation category. Hopefully we'll see a resumption in flexibilities for telehealth. Hopefully these will become permanent to allow increased telehealth use, particularly in the Medicare population. But also a lot of these communities still don't have broadband access. So there are a number of policy issues, I think, that can be important.
Well, and I just say it seems to me that we need more implementation, dissemination type science around telehealth to understand its strengths and weaknesses better.
And just to throw out a term that somehow we've not anchored on so far, we need team-based care. We've all been saying it without saying it, but really telehealth is the perfect way to engage a wide range of clinicians and support and all of the things in a way that you can't necessarily do all in one place all at one time. And so it really is sort of the facilitator for some of that excellent sort of high touch kind of work that you really need when you're helping someone, use a blood pressure cuff and figure out what the right medications are. That should not be once a year you come in, drive in, see your doctor, fight the traffic. That cannot be the model for how we deliver care, urban or rural. And so if we can do telehealth with team-based care, we could do so much more high touch that currently is not reimbursed, that's not valued, and is, we're getting what we're paying for, essentially, which is yearly visits for hypertension.
Karen, I'm so glad you brought team-based care up. Anand, when you were speaking, I was thinking about, cardiovascular health or disease prevention as the gateway for these other conditions. Because when you pull teams together, when you have a team and you have some technology that works for the patient as well as the clinical squad, and you've got timely data, you can make good decisions. All of those things, we're talking about them primarily for heart disease and stroke prevention, but they do apply to diabetes management, to obesity, to mental health, definitely mental health as well. So it's getting those things out
it's
there.
interesting. When we talk about disease, we tend to talk in silos. When we talk about prevention, it seems to me we can talk in a joint way that can work across all of our subspecialties. So we need to think about how to organize around that better.
And start early, right?
Yep, as early as possible.
Yes. Well, I think it's time for the lightning round. It's lightning only in that you can take as many minutes as you'd like, but imagine that you are making the business case for prevention, and you can do it either with the environment we're living in right now or your dream environment. Hopefully keep it somewhat reasonable, reachable through policy change. So who would like to go first?
Well, I can start off by saying that, we always say that good health is good business. And so much of cardiovascular disease screening and prevention is, if not cost saving, at least it's cost effective. And we know from a value perspective, so highly. We all know that when you talk about prevention, the reason you ought to focus on prevention is for better health outcomes. It's not to save money, but in many cases, particularly when it comes to cardiovascular disease, it's safe. And so I think, everyone who is attending today, know that there are opportunities with businesses in your community, state Medicaid programs, state employee health plans. There are opportunities where if these entities will elevate focus on cardiovascular risk factor reduction and prevention, that not only will they have healthier employees, but they would also save dollars for business, Medicaid program, if they any type of care, healthcare. So it's a double benefit here, and I think you're right. We ought to talk about it more, in that construct.
Yeah, it seems to me that there are some challenges in making this case, because oftentimes we're talking about things that didn't happen, and that's an outcome that is hard to express.
Right.
I know in the hospital setting, we now talk about injuries that didn't happen to children because of preventable harm. And I think maybe we can start to talk about these kinds of disease outcomes in the same way. But to me, the increased longevity and increased morbidity-free longevity is the thing that makes the case. That I think everybody wants and everybody can understand. The hard part there is, in many cases, as you talk to insurers and policymakers, et cetera, their interest is in short-term outcomes. And this is a case where we have to make the case for a long-term outcome, a really good one, but one that takes a lifetime to see the benefits for. So I think the case, I'm biased, I guess. I think the case is obvious, but it's one we have to really continue to explain in ways that people understand it and can then play out in various healthcare environments.
Yes, Steve took the words out of my mouth. I was going to say I'll take the flip side of the life course from the pediatric population and say that Medicare needs to invest in prevention, because Medicare gets all of us, right? We have sort of a societal agreement that at a certain age, we are all going to be taken care of by the government. So, hey, government, let's get a lot of really healthy 65-year-olds aging into Medicare and still being productive, and also being able to play with their grandkids and do the things that they want to do, but also having a longer, more sort of productive, adult life is something that everyone wants, and something that actually is economically positive, but you can't create that starting at age 65, right? And Medicare should be incredibly incented to push on prevention, because they get all of us. If we're lucky, it's a privilege to age into Medicare, right? And so they really ought to be the ones thinking broadly about how they can partner to get healthy.
Yeah, we would love for Medicare to think pediatrics. Good concept.
You heard it here first. Well, I think those are words of wisdom from each of you. During the discussion, I heard, how can we make prevention what the cool kids do, one form or the other. And because there is a big table at which that is set for many different types of organizations that are necessary in order to prevent heart disease and stroke, right? So we really have business cases for community-based organizations, for mayors that are now moving with the National Forum, and then federal agencies, certainly CMS leading the way in Medicare and Medicaid, and private payers, and then a whole slew of clinicians sweeping across primary care and pediatrics to those taking care of folks at older ages. And so breaking down that business case and making sure that the policy solutions advantage all of them, or at least keep them above water and don't disadvantage any, that is quite a puzzle. But I know that the National Forum hosts large collaborations, large and small, and can help us move the needle on this very important thing, and then spread the lessons learned to those other conditions. So on behalf of everyone here, I want to thank our speakers for clear, actionable insights today. We're going to now move into the Q&A. Please continue to send your questions through the Q&A feature. And I'm pleased to invite John Clymer, Executive Director of the National Forum, to facilitate the Q&A. John, over to you.
Thank you very much, Janet Wright, and Drs. Daniels, Joint Maddox, and Perek. Today's a travel day for Dr. Wright. We're grateful to you for fitting the panel discussion in, and we understand that you can't stay with us for the Q&A, but our terrific panelists are here. So as Janet said, please use the Q&A feature at the bottom of your screen to ask questions. I want to begin with a comment. I love the idea that you all hatched, that we should view a heart attack as a failure and strive to stop the failures. Janet is a fan, I know, of Hattie Reese-Hanley from the Right Care Initiative, who poses a related question, which is, how do we flip the script and stop accepting the deadly status quo? Who wants to start with that?
I'll start. I think part of it is events like this and getting a bunch of people together to say this is deadly. We cannot continue down this path. I think there's been a lot of emphasis put on chronic disease in the last 6 months, and we need to leverage the moment to try to figure out how to raise the opportunity to really attack chronic disease right now, particularly trying to prevent those cardiovascular events. Now, we can certainly talk about all of the barriers that are being put in place to those to that attack on chronic disease currently. But we have an opportunity right now to continue the momentum of the push toward chronic disease to try to keep it moving forward.
Thanks, Karen.
Well,
I don't know if
John,
you've seen
I
yet.
think you're going to know
Yeah,
what
go
I'm
ahead,
going to
Steve.
say, but it has to start with kids. We have to start early in life, maybe even in utero, to create this healthy pathway. And I think that we don't invest enough in child health, thinking about the return on investment that we get in terms of life course health. So I think there, as we talked about, should Medicare be thinking about prevention that extends to the pediatric age group? Yes, I think it should. But as a society, we need to think about how to make these kinds of investments.
Yeah, and John, I'll just combine both of those comments from Dr. Maddox and Dr. Daniels by saying that, what is topical right now, making America healthy again ought to be making America heart healthy again, and reversing the chronic disease epidemic. To really do that, you need to address the risk factors that we've been talking about today. So I think it's really prioritizing this. I'm so pleased that you had Dr. Oz here to join us, because CMS is such an important entity, perhaps more important than any entity when it comes to population health, and the levers it has through its innovation center, through payment policy, through its quality improvement organizations are so important. And so really getting this not only on the radar, but ensuring that policymakers and leaders understand that this is absolutely critical to their agenda. I think that is sort of the moment that we can't afford to lose right now.
Yeah, absolutely. And the emphasis there and on that the MAHA movement has on child health or early intervention certainly supports the prescription that all of you have been giving, that Steve has been dispensing for decades. I don't know if you all saw, but this is apropos of Janet's question about the business case. This morning's Wall Street Journal reports, and I'm quoting, "The cost of health insurance rose steeply for a third year in a row in 2025, reaching just under $27,000 for a family plan." And the journal says higher spending on chronic diseases, weight loss drugs, and hospital bills helped drive the increase. So cardiovascular, Anand, this kind of goes to your reference to that extremely lengthy title that we gave you. Cardiovascular, metabolic, kidney, and other chronic diseases are cost drivers as well as killers. And we need to do a lot of things to reduce the chronic disease burden, but it seems like actions often stall because there are just so many levers out there, or there's such diffusion of effort with so many hands pushing and pulling different levers that the effect is diffused and really almost nullified. So if we were to concentrate our efforts, everybody who's participating in this meeting, if we were to concentrate our efforts on just one or two changes, where would you start? I'm going to start with the because I know this is something you've thought about a lot. It's kind of at the root of prevention first. And then Karen and Steve, ask you to comment as well.
Yeah, I think that there are a couple of really important population health initiatives that I talked about. I think sodium and added sugar is really where we need to focus. And then on the clinical front, again, we have some initiatives. Diabetes prevention program has been brought up a number of times already today. The important work of Million Hearts and blood pressure control obviously has been brought up today. So we need to implement those interventions at a clinical level and scale them, the ones that we work, that we know that work. And then at the population level, we need to focus on these broader issues that sort of no one provider or payer can take on their own. So again, I think it's going to be ultimately looking within and outside the four walls of the clinical setting. It's going to be that combination of population health initiatives and clinical care initiatives that we really need to elevate and get both the public and private sector aligned.
Karen, would you affirm that, or would you do anything differently?
I'm just going to add on because
Yeah.
I think that the public health stuff, absolutely. And I know that Dr. Daniels is going to say focus on kids. So I will add one, which is to say, we really need to guarantee access to healthcare for everyone. And our healthcare system is too expensive. It is not reasonable for people to pay $27,000 a year for health insurance. That's an insane amount of money. People cannot afford that in this economy. And lots of people are going to go without health insurance. And Medicaid is going to be cut, and even more people are going to go without health insurance. And the people that are going without health insurance are the people whose cardiovascular health is at the tipping point, right? It's people who are in young adulthood. It's people who are on and off of, gig work as Uber drivers or as delivery people. It's a whole bunch of people at incredibly high risk. And we cannot continue to rely on this system of patchwork healthcare systems and patchwork insurance and think that we're going to make any progress on population health. We are fundamentally unable to provide a system of care, either in healthcare facilities or in healthcare coverage, the way that the system is set up. Now, that's a huge thing to take on. So I know that's unfair, but I'm still just going to put it out there as just fundamental to how we think about population health.
Yeah, and you just got props from Madele Ogani from Emory and Grady, who said she strongly agrees with prevention across the life course.
Thank you,
That's the key to making America heart
She's
healthy.
amazing. So right back at you.
Steve, prevention across the life course.
Well, yeah. And, John, I think a really important point here is that we're paying for things that are preventable. And so, we need to really flip the script in terms of just accepting that as a concept, which will increasingly become more and more expensive, and really focus on something that Anand has said, which is, how do we make the healthiest choice the easiest choice?
Yeah.
How do we work with, and this is really schools and government and industry all need to be working together to focus on how we can implement these lifestyle changes and how we can create the kind of lifestyle behaviors that ultimately will prevent these illnesses and save us all lots of money.
Yeah, great points. We all know that there is abundant evidence showing that tailored pharmacist services move the needle significantly in the right direction for health, and that they're cost effective. And yet there are all kinds of barriers to people taking advantage of those and to society gaining the benefit. To your point, Steve, about paying for things that don't make sense. So Jeff Durthaler said in the chat that we need universal access to evidence-based clinical pharmacy services. And Karen, Ben Blummel from the APHA Foundation told me that earlier this month, Dr. Oz told the Aspen Institute he believes that advancing the role of the pharmacist is essential for rural health transformation. What say you?
I completely agree. I think, rural health may actually be a place where we learn a lot in the next couple of years, because there's going to be innovation and creative thinking around how to do care better. And fundamentally, we can all learn from what that looks like. And I think what we're likely to see with the rural transformation money and with sort of a shift in thinking around rural health is moving more toward health hubs that are stable, funded infrastructure hubs, as opposed to relying on sort of fee-for-service, pay-for-knee replacement type of work, which is just not how you can fund prevention. And so if we think about rural health as maybe an opportunity to innovate, that has got to include team-based care. It has to engage schools which in rural areas are some of the best infrastructure that we have. And so I think there's a lot of creative ways to think about partnerships with FQHCs in schools, think about rural health hubs, think about technology, and we'll see what we learn. But I think team-based care is central to all that. And actually, pharmacy, community health workers, nurse practitioners, therapists, there are huge opportunities to really train workforce in rural areas as well, in a lot of these areas that are really sorely needed.
Thanks, Karen. Now, I'm going to shift to a related and I mean, there's no beating around the bush. This is a politically indelicate question, particularly since I'm posing it to three people who have MD after their names. But it's a major factor. Karen just talked about team-based care. We've heard other people talk about it, other panelists, you all. We know it works, right? We know people benefit. We know it's efficient. And yet, we hear over and over from the medical guild that it has to be physician-led team-based care. That's the only model that they find acceptable. And at the end of the day, when state policymakers are considering models, reimbursement policies, or scope of practice policies that would make team-based care easier for people to access, it's often the medical guilds who get in the way to protect the status quo. So how do we change that? How do we move forward so that, I mean, I know you all embrace team-based care and people's access to evidence-based care. How do we get the rest of physicians on board with that?
Well, and John, I think it's important to say that different people can look at teams differently. I think the concept that every healthcare team needs to be led by a physician is a ridiculous concept. And one of the things that I think we don't do very well is, while we're working more and more to deliver care in teams, we educate in silos. So we need to transform our medical education environment in a way that we actually are educating in a team-based, interprofessional kind of way. And I think we, by doing that, could actually really enhance the ability of teams to work better together, but also enhance the understanding of what the various roles are that people can bring to these teams, and emphasize people working at the top of their scope in a way that ultimately produces the best result.
Yeah, I'll just add that I think when it comes to medication therapy management, particularly for cardiovascular risk reduction, there really shouldn't be any opposition. Now, I know sometimes there are turf wars and things like that, but really states, and I think a lot of the action is at the state level, scope of practice and reimbursement should facilitate pharmacists performing medication therapy management. And again, a lot of the medications we're talking about here, frankly, are generics. They've been around for a long time: antihypertensives, lipid control agents, anti-diabetic agents. Every time we can sort of reiterate, reaffirm, ensure that patients are hearing the messages about adherence and cardiovascular risk reduction, the better. So this is something that I think we all need to come together on and embrace.
Yeah, you
Thanks.
both said it more politely than I would have. I think it's a ridiculous argument. There are so many people who need care. There are so many people who don't have access to care. There is plenty of work to go around. We can all work together, and we need to focus on keeping people healthy. That is our job, right? Not fighting with each other. And I don't know exactly how to get around that, but I will say that I don't think that the guilds represent actually the majority view of physicians in all cases. And I think it is changing with time. Team-based care is becoming much more the norm. It is much more in training already. And I think that this is changing, and I hope will continue to change, and we should all push to continue to change it.
Yeah, I'll just add that, we talked before about really having to work across state lines. Unfortunately, I think the guilds contribute to this state-based sort of protectionist view of how we deliver care. And I think we need to get past that. We need to think more globally and be able to move across those barriers.
Wow, a lot of big picture thinking here. Thank you. We have a lot of questions, so I want to keep this moving. Darwin Labarth asks, do we have to invent a new care or payment or community model, or are there successful models we could implement now? He mentioned that Don Lloyd Jones referred to Finland's North Karelia project. We know that the North Karelia project slashed cardiovascular disease mortality and added 7 years to life expectancy. And Don also mentioned the success of the Cardiovascular Public Health Initiative in rural Franklin County, Maine. And that initiative raised blood pressure control and cholesterol control by, I think it was 25 and 29 percentage points, respectively. Um, Now Greece has what appears to be a successful new initiative underway to effect a shift from this norm of I go to the doctor when I experience symptoms to I go for preventive care. Do you all hear people talking about, are you talking about these or other successful models? Are there some that we should look at as a beacon on the hill?
Well, we've been talking about or lamenting the fact that we have a sick care system for many, many, many years now, and hoping that we'll move to a healthcare system. But we are still very much in the throes of a system that we access only when we are ill or quite ill. And so I think what you're talking about, John, is how do you flip that so people view the system as a system to support them in disease prevention, health promotion. And that is sort of a fundamental shift. Now, I think on the healthcare payment side with value-based healthcare transformation, we talked about this a little bit, but getting the metrics right to incentivize providers to not just manage cardiovascular conditions, but prevent them in the first place. I think there needs to be much more focus in that area. And then on the patient side, as we've talked about, much more facilitation. I think the education piece on both sides is important, but most people understand what they need to do, but they need some support or assistance, whether it's accessing healthy foods or getting generic medications or getting access to care, which is a critical point. And so I think that's really where we need to focus. I don't think that there's some magic payment or delivery model or something new. Again, we know a lot we know what we need to do for the most part. We know what works. We need to facilitate the pathway for patients, and we need to better incentivize providers so that they can provide the care that they want to care, but the system doesn't always facilitate that.
Yeah, so John, I'd like to comment from a pediatric perspective. I think that most people don't seem to recognize that the majority of pediatric patients are actually covered by Medicaid. People don't think of Medicaid as a pediatric healthcare finance system, but in fact it is. And I think it's problematic because Medicaid is a state-based program, which means that we have kind of an archipelago of different ways of financing child health, when in fact we need a more unified way, because that's the way we could create more efficient and effective systems and get better health, I think, for a lower cost. So my view is that we need to think about changing the healthcare system for children and have a federal Medicaid program focused on kids, rather than having children and pregnant women wrapped into a bigger Medicaid system that tends to break down in a number of ways. So I actually think we could get to a much better place if we started having these kinds of conversations.
Thanks. Karen, we're down to 4 minutes, so I want to move to the next question and ask you to answer it first. Dr. Bill Baumer says we may have to close 200 to 700 rural hospitals in the US because of the loss of rural hospital subsidies. How can we financially support rural hospitals? Karen, you referred to the rural health bill and also about the collective policy problem of prevention, needing to reward prevention more. It seems like a lot of these tie together. And is the rural health bill part of the solution? And if so, how? What else do you see out there?
Yeah, the rural transformation money is not going to make up for the lost money in Medicaid and other subsidies, according to policy analysts. We'll obviously have to see how it plays out, but it will help facilitate some stability in rural areas. And that'll differ quite a bit by state because the way the money is divided, that half of it is divided evenly across 50 states. And obviously states are very different in terms of their population. So in some states, that money is going to go a lot farther. And the other half will be divided competitively through a formula that has been released, but is a bit difficult to see how it'll play out. So there's a lot to keep an eye on through applications are due in a couple weeks and the money will be awarded at the end of the year. So a lot to keep an eye on in rural health. I think some states have gotten ahead of this. So Pennsylvania, Missouri, a few other states have done, Maryland have done work to try to stably fund rural hospitals by saying basically you all can't live and die on fee for service and you get one sick patient and you're bankrupt, like let's just fund you. And those have been successful to some degree. They haven't seemed to improve quality or outcomes much, but they have led to some financial stability. And I think the rural emergency hospital program, which also is sort of puttering along, where hospitals can voluntarily convert to emergency status only, but get, again, stable funding, is another existing mechanism where we might see some movement. So I'd say there's a lot of solutions on the table, but people have to be willing to fund rural hospitals completely differently than they fund other ones. And I think this moment in time with the bill is actually making states have that conversation. So I suspect we'll see a lot in the beginning of 2026 around trying to stabilize those hospitals. Is crucial.
Thanks, Karen. I think you just added significantly to many people's insight on that. So thanks.
Well, and John, I think
we're
it's
down
important
to the
say
last
that
minute. So
children's
Steve,
hospitals are also vulnerable to the same risks as rural hospitals. So, because of the Medicaid base, we really need to worry about children's hospitals too.
yeah, absolutely. And that's coming from the perspective of someone who is serving kids from all over the state. Yes?
Yes, and we live this every day. And, I think some of the things that are looming out there will have very serious negative implications for children's hospitals around the country.
Yeah. Thank you. Anand, final word.
Well, I mean, I think this conversation is just so important. And, one of the things that, that I'll just mention, obesity, I think as something that we all need to also sort of keep centered, because it is really the rise and prevalence of obesity as the prevalence of tobacco use has come down that has contributed to where we are in terms of cardiovascular disease and all the risk factors, whether it's lipids or sugars or blood pressure. And again, looking at food, environment, and health, clinical community interventions, those underlying risk factors. So obesity on the childhood side as well as the adult side, obviously critical to this conversation as well. So just wanted to make that point.
Thank you very much. Steve Daniels, Karen Joint Maddox, Anand Parekh. Wow, terrific conversation. Thank you. All of you have certainly added to my insight, and I suspect for many of the National Forum members and participants who are with us today. So thank you very much. We appreciate your participating in the meeting as speakers. And I also appreciate all the great comments and questions that people have been posing and putting into chat.